would say one of the other really hot concepts at World Lung and various other meetings is combinations with immunotherapy. And that can be two different immunotherapy agents, perhaps a drug like Yervoy, ipilimumab, which is a CTLA-4 inhibitor that really targets a different part of the immune system in combination with these immune checkpoint inhibitors, or like PD-L1, PD-1. Or, as we have alluded a bit to, chemotherapy in combination with immunotherapy or a targeted therapy. How excited are you by some of the combinations, starting with, say, the different immune therapies combined together? Is this incrementally far better than any one of these drugs? And is it financially possible to do this in the world we live in?
So I think in melanoma, the combination data looks super exciting. I think the combination of ipilimumab and nivolumab looks really impressive, particularly in PD-L1 negative patients. And it has to be said, even that data are relatively early data. We know that it improves progression-free survival. We're yet to find out whether this changes overall survival. In lung cancer, I think Leora probably has been involved in some of the studies, but I'm not sure that we're at that stage with the data. We're relatively early, and the early studies were hampered by a lot of toxicity in the patients. And I think at this meeting we saw some slightly different schedules that might have improved the toxicity, Leora.
Of course, we do need to be mindful that melanoma patients are often quite a bit younger and healthier than your average lung cancer patient. So what is your thought on this now?
I agree that the data is very early. The metamune with tremelimumab combinations and the nivo and ipi combinations, but the toxicity I do think is going to be a big issue for lung cancer patients. They are older, they're just not as hardy, and the toxicities are not inconsequential when they do happen.
Yeah, I think that it's appealing to think that maybe combinations will work in a broader range of patients in whom a single agent may not be enough, and that hopefully in a few years we'll be able to predict reliably which patients are best served by a single drug versus a combination, if we can find combinations that are tolerable.